as well. Thank you very much, Dr. Srinivas Kumar, and all the faculty members from Apollo. Great to be with all of you. I just wanted to say, we always have to remember our past. Without great people like Forsman and Soames and Daughter, we wouldn't actually have a field of interventional cardiology. And I think some of the DM or DNB students should know about each and every person who has helped us to have this field, and should pay tribute to them all the time. And poor Forsman, he's the first one who did a catheterization on himself. And to have an evidence, he took his girlfriend, who was a nurse, and tied her down to the chair so that she can witness, but she couldn't stop him. And put a catheter in the basilic vein, actually a urinary catheter, and advanced into the right heart, and took an X-ray of himself, saying that this is how he has shown. Poor guy got fired, and the nurse also got fired from the hospital in Germany, and he became a urologist afterwards, and he never could become a cardiologist. And he later on posthumously received the Nobel laureate, Nobel Prize. So, and that interventional cardiology, on the heels of such pioneers, and Andreas Grunzig started interventional cardiology, as many of you know, in 1977 was the first PTCA that was performed. But let's come to structural, and without that, we would not have all these ideas of doing many catheter-based treatments for structural heart. So here is a 21-year-old male with the ischemic stroke that I had, and we actually treated him with the PFO closure device. And as you can see, the left disc is smaller than the right disc, and this is Abbott Amplatz PFO closure device. And we always have a team of neurologists and cardiologists who decide whether the patient should have a closure device or not. If anybody can recognize him, on the left-hand side is Amplatz. Okay, so he's still, I think he's probably 94. He still works at St. Jude or Abbott now in the Amplatz office, and he still teaches students. But the first talk about actually a closure device was done by King and Mills in Texas. And that's how we actually started off looking at closure devices in PFO and atrial septal defect and the ventricular septal defects. But that's not alone. Now we have a WATCHMAN device for left atrial appendage closure, and also Amulet that is also available, I think, in India. And so these are left atrial appendage occlusion devices, which are basically made of nitinol structures, and the different sizes that are available now. Actually, we have up to 35 millimeters, and it's called WATCHMAN Flex, which is a little bit more forgiving, less, a little bit atraumatic, and than the original WATCHMAN device. And in people with the atrial fibrillation, with the stroke, and who cannot tolerate anticoagulation, right now it is been approved for such group of patients. But we're also participating in clinical trials comparing the WATCHMAN device versus oral anticoagulation in patients who had prior atrial fibrillation or ablations for atrial fibrillation. So this is the fabric cap that is actually very good in filtering all the clots and making sure that there is no clots that can come from the appendage or to the left atrium or vice versa. So WATCHMAN device is very simple. We normally go into sorry, these are not playing, but transseptal. We go at inferior or and mid rather than anterior or posterior. We go to the inferior fossa and the mid fossa and get the pigtail into the appendage, and then easily deploy this WATCHMAN device. And as a routine, we do about 4 of these a week in our hospital. Every Tuesday, we do 4 WATCHMAN devices for atrial fibrillation patients who cannot tolerate anticoagulation. Why do we do that? As you can see, whether it is WATCHMAN or Amplatzer, there's a great reduction of stroke with the devices in patients who cannot tolerate anticoagulation. The major bleeding rates are also much lower with the Amplatzer plug, as was shown in the AMULET trial. And we participated in both the AMULET and WATCHMAN trials. So that is about the left atrial WATCHMAN, and the future is actually going to be much more probably bioresorbable, both for PFO closure devices. We are going to participate in a bioresorbable PFO closure device, as well as in probably in the future will be a WATCHMAN device that can be resorbed over time. And the next thing is actually looking at how, if you remember some of these great people, and here is in 1977, Andreas Grunzig did that, and then about I think 1978 or 79, this gentleman from Danish, he went to listen to Andreas Grunzig in Phoenix, Arizona, a talk. And he then worked for about 10 years or so and trying to form a device which is a transcatheter aortic valve device. And this is a Henry Rudd. And for 89, I think he just finally figured it out that he could do it. And then for another 6 years until 93 or 94, he was still designing it and nobody bought it. Everybody ridiculed him, including Medtronic and big companies like such as Edwards. And later on, a group of physicians and such as Martin Leon and Alan Cribier, and they formed a group and they bought his company, which makes his patent, and which makes these devices. And this in 2004 became a reality when Alan Cribier used the first transcatheter aortic valve replacement with the SAPIEN valve. And in the background is Henry's dad. He underwent a TAVR, I think, back in maybe 2007 or so. We were lucky enough to see a video of him actually. So this was the original patent, and now this is how it is taken several generations later, how it looks. And at the same time, this is another person, Fred St. Gore, is another cardiologist from California in Palo Alto. And he listened to another surgeon's talk about, so I'm trying to say, this is a cardiologist, a surgeon got the idea. Here is a cardiologist who got the idea of a Mitraclip from a surgeon's talk called Alfieri. Alfieri was giving a talk, and then he listened to that, and he said, okay, this is Alfieri's stitch. And then he was on a flight going back, and he entirely designed the whole Mitraclip on a piece of napkin they gave him along with a Diet Coke on the flight. And so he designed that, and I had the pleasure of talking to him back when we did the first Mitraclip in 2009. So this is Alan Cribier, sorry, not 2004, 2002. He did the first gentleman, but here, this unfortunately, this patient died within 30 days. So catheter-based mitral valve repair, will start with mitral valve, and will further go on. So this is what Alfieri's stitch used to be, and then this is the currently available Mitraclip. And now in India, you have many centers opening up, and the Mitraclip is very simple to do, very safe. I actually think that Mitraclip, in my opinion, equals to treating stable ischemic heart disease patients, because patients are stable. Nothing will happen to them unless we really do something wrong. The procedure is actually very good and very easy to do. And but the machine looks very complex. The end result is really very. Here is a patient with a severe MR. We did it in this gentleman in 2009. He was an 84-year-old man who was a class 3 to 4 heart failure with multiple hospitalizations, and post-clip MR was reduced from severe to maybe 1 to 2 plus. And with that, he survived for another 5 years. And then he finally passed away at the age of 89. As you see, fluoro and transesophageal echocardiogram. are very important. And to have an idea about if we are interventional cardiologists, we now have to start thinking about how to interpret the transesophageal echo in the surgeon's view, and exactly know where we should deploy the clip and how to make it much simpler. And obviously, this takes a little bit of training. And my first Mitraclip took 45 minutes. The second Mitraclip took 4 hours. So you have to really be very good in it. Now, average, it takes about half an hour to 45 minutes or so. So there is a learning curve, and the utility of 3D echo is very important in interpretation, as I mentioned. And you can actually base completely on the 3D echo how to deploy this clip as well. At the end, you create a bridging between the anterior and posterior segments, A2 and P2 segments of the mitral valve. And you can see a double inlet mitral valve that is very good. And I don't think I need to show a video, but so this is a very complex one. And as you can see that, and you can they have to be perpendicular. So in EVEREST trial, actually it was the first trial that we participated in, and EVEREST 2 came out later. It is a randomized controlled trial looking at a primary or degenerative mitral regurgitation and how patients have improved compared to the control group, which is by surgery, versus the device group, which is Mitraclip. So about 88% of them had a class 1 to 2 dyspnea in the control group by surgery. There is definitely greatest reduction by open heart surgery or a mini thoracotomy or robotic mitral valve repair or replacement, versus actually there's 98% of them had class 1 to dyspnea. So it did not matter how the patient was treated, but device group people, how severe the mitral regurgitation reduction was. Obviously, in device group, we could not get a 0% MR, but their patients felt much better. So what matters is how the patients feel. And in survival, there is no difference between the surgery and device group at 5 years in primary MR patients. Henceforth, in United States, it has been approved for primary MR. And now let's look at COAPT study, which is a heart failure study in people with the functional mitral regurgitation, where the guideline medical therapy alone is enough, or Mitraclip added any benefit to guideline-directed medical therapy in terms of reduction in all hospitalizations. What I expected was definitely that it will show, because we saw the results of Mitraclip in these patients. And this is a very difficult trial to complete, because anytime we make some adjustments in the diuretics, more than 50%. So if from 20 milligrams of Lasix, we go to 40 milligrams, we have to actually wait for enrollment until the patient is stabilized on that for 30 days. So no changes should be made on guideline-directed medical therapy. What it showed was that absolutely the hospitalizations were much better with the Mitraclip arm, much lower in the Mitraclip arm as compared to guideline-directed medical therapy alone. So this was not a surprise. But what was surprising also was that it had a similar reduction in survival. The number needed to treat for Mitraclip was 5 in patients with functional mitral regurgitation. Henceforth, now FDA has approved it, and also the insurance companies have accepted to have patients treated with Mitraclip in heart failure. But we do need a heart failure specialist to sign off on the patient that the patient has been on guideline-directed medical therapy for a month at least. But not all patients can be clipped. So there's a lot of all these patients cannot be clipped, as you can see. And so then there are other things that are coming out, and it's saying that indirect annuloplasty, caudal repair, and some of them are LV remodeling. None of these have seen the daylight yet. They're all in clinical trials. And millipede is something that is interesting. We can talk about that if anybody is interested, but they're all in research currently. I'll come back to the future of Mitraclip and where we stand. So, but let's look at the present nature of aortic stenosis, as we saw very eloquently been shown this morning by Dr. Sengutuvel from Apollo Chennai. And but a team of surgeons, cardiologists, anesthesiologists, echocardiographers are required. And this has become a norm even in India to treat severe aortic stenosis, whether senile calcific, that's what we see mostly, but in India and other places, bicuspid younger patients are seen because I think due to affordability of the device. And so I'll skip this video because Dr. Srinivas Kumar has shown this in the earlier. Okay. And so nowadays, all transfemoral procedures are being done with the TAVR. But our alternative approach for TAVR, nobody has talked about that, is actually a right carotid. In our center, that's what we prefer. Our surgeons are very good at doing a small incision as they're used to doing carotid endarterectomies. And from there, it is almost like a direct approach to the to alternate axis. So if we cannot do femoral, we always go from right carotid. And so this is another patient of PORTICO, and which is also now coming to India much earlier than actually it would make it into United States. And so you can see PORTICO also is a self-expanding valve, similar to Medtronic, but it's I think it will also give some benefit for lowering the cost of these valves in India. We participated in that, and EVOLUTE Pro is what we use in the United States. It has a little bit more skirt at the end to reduce PVL and enhance the sealing and the redesigned outflow to lower the gradients. So S3 Ultra is what we currently use in our program, and newer designs to reduce bundle branch blocks by maybe foreshortening a little bit more on the ventricular aspect, and actually looking at similar to regular S3. These are very good and very easy to implant, and any patient with the high-risk features such as septal bulge or calcification in the aortic ascending aorta or aortic arch, we use Edwards Sapien S3 Ultra valves. Sorry. So there's definitely going to be a growth of TAVR procedures, both in the US and Europe and in Asia. There's no question about that. As we started off in, I started doing in late 2009 or 2010, January. And now we definitely are seeing a huge increase. We do about 170 TAVRs a year in our program, and but low-risk patients also have the chance of getting robotic aortic valve replacements, which is being done at our center. So the Partner 3 data, which is, Partner 2 intermediate risk data, which has actually shown that in intermediate risk patients, Sapien 3 transfemoral versus or transapical versus SAVR. But if you look at the transfemoral group alone, there is a huge benefit than actually transapical. And the transfemoral mortality is 6.5% mortality at 1 year, which is equivalent to surgery on in the intermediate risk was about 13%. So definitely superior. P2A, that is the intermediate risk, surgical risk is at 1 year is 13%, whereas if it is transfemoral, it comes down to 6.5% mortality at 1 year. So this is a great study that now we are able to show that transfemoral has a lower mortality than surgery. Do all surgeons accept it? No, and unfortunately they don't. We still need to think about patients who are less than 75 years of age. Getting a great result is very important. So please, use all the teamwork that your team that you have to achieve those fantastic results. So aortic stenosis is now redefined in functional classification. That means if somebody has severe AS and all of them go for a TAVR, if somebody has severe AS without symptoms, we are trying to see whether there's something called a moderate, TAVR unload study, and moderate aortic stenosis. We can do another TAVR as well. That's a TAVR unload and early TAVR in severe aortic stenosis patients. So I think now we started using TAVR in most of these patients, and the only patient that will be left is moderate aortic stenosis without symptoms and mild aortic stenosis. For annually, we'll be watching them over. So active surveillance is required in them. So if you're not involved in the TAVR, I think it is too late. Probably you should start getting involved. The TAVR train has left the station for multiple new stops, actually coming out from US, UK, and to the rest of the world already. So one other thing that in structural, or whether it is structural or not, we can debate about it, but we in our center, we are going to be doing this resistant hypertension or any hypertension patients with cardiologists will be putting catheters in the renal artery and doing renal artery denervation. This is going to be approved probably by the end of this year or first quarter of next year, where FDA is going to approve this product here in the United States. And that is, as I mentioned, not only to treat resistant hypertension. The simplicity trials initially showed some benefit in resistant hypertension, but now on-med and off-medication trials have been done. So the patients who are having symptoms on antihypertensives, well controlled, can still actually come off the medications and after undergoing renal denervation. So then next is actually heart failure. I do these once in a while. We can actually implant these transducers and into the pulmonary artery, just like a right heart catheterization. And the transducer can transmit PA pressures constantly, like an indwelling Swan-Ganz catheter. And we can adjust our nurse practitioners or pharmacists can adjust the medications based on the data that they receive. So this is a team of cardiologists, primary care, heart failure nurses, and pharmacists and case management actually will make it happen that we do these. And this week I have one more patient of ability to do them. The trial that showed a champion trial, which has shown that reduced hospitalizations by about 36% in people who have used CardioMEMS device. Okay. Acute PE, I know time is short. I'm going to quickly talk about a few slides. The team here is intensivist cardiologists and cardiac surgeons and perfusionists, because we are able to take out such big chunks of thrombus by using devices such as AngioVac, which we have in our center, or in moderate PE patients, you can use ECOS catheters as well. So TEE, I think, is going to become a gold standard for all structural cases. So make sure that you have a very good person who can do TEEs in your center, or actually send them to for any center for observation for a couple of months. Here is a quick case of mitral valve in valve. And after doing the balloon septal dilatation, then you go ahead and you cross it. And in 2 views, you can look at it. And then you implant slowly and mitral. If you want to pace it, you can. If not, you don't need to. And Dr. Sai Sati showed a nice case of TMVR this morning, which was very complex. On the coming back, we probably ruptured the septum a little bit. So we closed that with the closure device and atrial septal defect closure device. And you can see great reduction of mitral valve gradients after the deployment of this valve. And so septal closure is also done. I think I'll just quickly. So whenever you want to do Mitraclip, when it is not possible, what is the future? The future is going to be like this patient who had undergone TAVR in the past and type 3 Carpentier MR with multiple admissions for heart failure. And because of the failed gap, we did not feel she's a good candidate for Mitraclip. So we went ahead and did transcatheter mitral valve replacement, which is done with a transapical incision. And so this is a place that where cardiologists, cardiac surgeons work together. And as you can see, there was a core valve, valve-in-valve, and that patient had, and then a tendine. Tendine is done via transapical, and it is tied down to the anchor to the LV apex, and so it remains in place. And the beautiful results that you get, there is no MR after the procedure. So in our center, we have fourth center in the United States enrolling patients very quickly. We have done about 14 of them till now. So we can do it in MAC, we can do it in mitral regurgitation. So other valves are available, but in view of time, tendine has been shown to have the lowest mortality of about 3.3% all-cause 30-day mortality compared to all the others. And we are happy to be part of tendine. How do we decide which one should be done? Based on a valve, mitral valve size. If it is smaller than 4, we go for valve replacement with the tendine. If it is 4 to 5, we can do a Mitraclip. If it is more than 5, you do a Mitraclip and an annuloplasty along with it. Okay. And what is the future for? I think the future is going to be tricuspid. It's similar to Mitraclip. Everything now we have in Mitraclip is going to be transferred to tricuspid valve, and it is a forgotten valve, and we are going to be treating tricuspid now extensively with the Mitraclip or TriClip, it is called, Millipede, and all these other devices that are available. So I think this is the last few slides. The team approach is very important. It will improve quality. It will definitely, I think Dr. Srinivas Kumar, Dr. Rath, and all the seniors have started this process of getting all Apollo hospitals in the country together. That will be a great result, and the end result will be improved quality across your the country, across Apollo hospitals. And collaborating is very important because it will give the best patient care, and it also will improve your capabilities of providing research, and your patient outcomes will be much better. And with that, I think I'll stop. So I think there is a structural interventions that are being performed individually, but I think a team of multi-specialty individuals will lead to better outcomes. And collaboration is extremely fulfilling, and barriers can overcome. The case mix and volume positively influence. I think, well, at least in our center, we have 4 structural people. We always have a teamwork. We work with each other. And obviously, there are some barriers in India, such as financial. Those, I think, can be dealt with newer devices that are coming in, and which will reduce the cost. And what we care ultimately is about the best care for the patient, and not who controls the treatment. Even sometimes, if it's my patient, my colleague will be treating, and vice versa. So I think it is best to make sure that the patient's outcomes are kept in mind. And the collaboration between all Apollo hospitals is what I think in the future is going to be, along with the surgeons being involved in their care. Thank you very much. I'm so sorry that I rushed through, but please ask me any questions if you have.
Thank you, Ramesh, for the excellent talk covering the various aspects of structural heart interventions. And as you said, these are here to stay because patients improve dramatically with these procedures, and whatever benefits the patient has to stay. And all of us need to become comfortable and form teams like you all did, and do more good to these patients. Any questions for Dr. Ramesh? Dr. Triptidev, Madam, Rath sir, anybody? I think all of them had an exhaustive talk, and they're all, Madam, anything?
Dr. Ramesh, very good lecture, and I really enjoyed that journey through the past and then coming to the present and looking at the future. And I'm really very happy to see such a good lecture and such a fantastic lecture in such a short time. We have covered the entire cardiology of structural heart. And so far, I have not done a single case of the structural heart. No TAVI, no MBR, nothing, no mitral clips. But many patients did come. But the cost is prohibitive. I don't know how to make them understand and get some insurance policy for them to go through. But they need it very badly. At least mitral clips, I had 4 or 5 patients, those who suffer with very severe MR, but we could not do that. And surgically, they are prohibitive because they have so many comorbidities. So that's what I was thinking.
Yes, ma'am. Absolutely right, ma'am. I think competition, I think, breeds quality as well as probably cost reduction. I think, as you've seen in the TAVR world, already there is a reduction in the price of valves with different companies, and hopefully Mitraclip also will have their competition, and which is good for us and good for the patients that they can be served.
If you see, Mitraclip is a small clip. It costs so much. It looks very odd for the patient care because unless we indigenize and do something as alternative therapy, these costs won't come down. Clip is a small clip, and it costs so much. That's the technology anyway. Technology and comes with cost, and hopefully it should come down to improve our patients. I think.
Can you just?
Yeah, sir. Please go ahead.
Yeah, Dr. Ramesh, what is the role of mitral clip in relatively young patients with severe MR? And also, what is the role of TAVI now in patients below 60?
Yeah. So the number one, I think Mitraclip in young people who I think in the United States, they are not going to be reimbursed if they do not see the surgeons. So the surgeons have to see them. If it is a primary mitral regurgitation, they have to say that they're high risk. If they're not extremely high risk, they will not get, the insurance will not reimburse them. So, but the second part is if it is functional mitral regurgitation, there is still a role, even though they're young. The surgery also has not been shown to be beneficial than medical therapy in functional mitral regurgitation. So in that group of patients, I think that there is definitely a role if the EF is 20-25%, rather than subjecting them to surgery. Mitraclip is much simpler and easier to do it. And in the future, our surgeons are very comfortable in case if they need another mitral valve surgery, they're able to go ahead and take the clip out and try to repair it. And for aortic valve, and I know similarly, we would never actually treat the youngest one I'm going to treat an aortic valve is next week, who is a 62-year-old. And whereas I think in India, it is different. People will come and they want to spend money in younger people than older people, I guess. And and bicuspid valves as well. So it is a different in not only in India, even in China, Asia, younger people are being treated with the TAVR more than United States.
Dr. Badri, any comments or questions you have, or shall we see you? Not able to hear you. Unmute.
Yeah, nice presentation. I've enjoyed it. Not only any mitral valve clip and sex variation for results, like you have peripartum cardiomyopathy. Some patient did not recover, have MR.
Yeah.
Any mitral
So
clip?
those are, yes, sir. Those patients definitely benefit. Those come into the mitral functional mitral regurgitation of the study, and the only time that Mitraclip is not beneficial has not been shown to be a good thing is if EF is less than 20%. We did do some of those patients when the EF is very low. Most of those patients do not survive. And so on a compassionate basis, back in 2011 or something, we did that. And I would not advise if the EF is less than 20%, I would not advise Mitraclip. They should get heart transplant.
Thank you, Achi. Dr. Gokul, Dr. Ramya, Dr. Ravi, anybody has any questions or comments? Because Dr. Ramesh might have to leave because it's a working day for them.
Sir, I have a question.
Yeah.
Sir, I have a question, sir.
Yeah, please.
Sir, it is a very nice presentation. And so a number of good interventions. Just my question is, have you tried the tricuspid valve regurgitation, putting a device in the IVC or SBC to reduce the tricuspid regurgitation? And
Yes,
what is the outcome? How much the patient will get benefited in the long run?
Mostly those are done for I personally have not done the IVC and SVC stents that have been placed, and so that has been done, but they're still in clinical trials. We are not one of the trials for that. There are several other devices that are coming in heart failure, such as a right-sided balloon pump for some few 24 to 36 hours. So those are all still investigational, and we need more data for that.
Okay.
One of the Indian companies acquired the trick valve, and they're wanting us to do some cases.
Yes,
Hopefully, let us see. Thank you, Ramesh, for an excellent talk. And